right, I think we are live. Welcome, everybody. Thank you so much for your patience as we got on. I wanted to just go ahead and get started in the interest of time. We are a couple minutes over, so I've got Dr. Shah here today who will be presenting on the UltraMIST, and we're very excited to hear from him and the content that he has prepared. So I will go ahead and share that.
Thank you, Bailey.
All right, and then really quickly, feel free to put questions in the chat. We will have some time for answering them at the end. And then if you have additional questions or want more information, you can go to our website, venturemedical1.com, or reach out to anyone on our team or your relationship manager for more information. Okay, go ahead, Dr. Shah.
Perfect. Thank you so much. And very excited to speak to a large audience here today in the afternoon. So we'll try to keep some time at the end, as she mentioned, to keep this engaging. And so I'm not doing all the talking by the end of this discussion. We have a lot to cover. So a little bit about me. I'm calling from the West Coast, particularly Arizona. I've been living out here for about 20 years and practicing wound care for a little bit over that. I am the medical director for a level 1 trauma center here in Phoenix, managing advanced complex lower extremity wounds, but wounds basically from head to toe. I've covered many long-term care facilities in the wound care arena, and worked also in the academic setting, as well as teach frequently with medical schools and medical students. And what we're about to talk about today is really using ultrasound therapy to treat chronic wounds. And that's near and dear to me because I've been using that for approximately 15 years as well. And I want to share with you my excitement about using advanced modalities and teach you a little bit about covering what ultrasound really is and how it works, what the science is behind it, what's the physics and mechanism of action. So we'll get a little technical here, but not too technical so we don't lose everybody. And then we'll talk about where can we use some ultrasound techniques to help heal wounds, what are the optimal wound types, and then what kind of patients can we really select to apply this technology on. Not very familiar with the audience here, but if you've been in the wound care arena for a while or working with wounds, there's several kinds of devices, several tools out there, many things out there to help heal wounds. But I truly believe this should be a big part of that toolbox when it comes to treating chronic wounds. So we'll talk about why. Next slide, please. Okay, so we're going to jump right into this, a little bit about ultrasound. And many of you may probably work with ultrasound or seen ultrasound, especially if, the women in the audience, if you work with ultrasounds in the GYN office, that's often used for diagnostic purposes, and the vascular offices for diagnostic purposes, which means we're getting information back to seeing what's going on underneath the body, underneath the skin. In this case, we're talking about ultrasound to actually treat something. And the ultrasound, which is really sound energy, has an effect on a cellular level. And it's sort of what we call a mechanical transduction conversion. So it's where we use mechanical and sound energy to get a response from the cells, right? So it's sort of a push-pull phenomenon like we do with negative pressure therapy. If any of you are familiar with that, where you're actually touching the wound with a device that's sucking on the wound to help fill in and remove the fluid, but also stimulate growth. In this case, we're doing this without touching the wound by actually displacing sound energy, touchless, if you want to call it that, for just simplicity, where that cellular response is really coming from the sound, causing compression or a push-pull phenomenon, and then causing some tension and shear stressing. So cells are getting activated, and they're going to respond to this energy. Then we'll talk about really what that response is in the next slide, please. Okay, so that sound energy, as I mentioned, is really at 40 kilohertz, which is not at the hearing frequency that a human ear can hear at. So you won't hear this sound when you're treating the patient with ultrasound. As I mentioned earlier, it's non-contact, so you're not touching the patient. They're not going to feel any pain. If anything, they're going to feel less pain, and we'll talk about that. We couple it with saline or salt water, if you want to call it that, because sound travels faster in liquid than it does in air. So you and I speaking, sound travels at a certain speed in air. If we speak theoretically underwater, if I could do that physically without drowning, that sound would travel faster in water and get to your ears faster. And if it was within a solid medium, it would be even faster than that. So the denser the medium, the faster the sound travels. So in this ultrasound device called UltraMIST, we do couple it with saline. It's kind of like we call it mist because you're misting that water. And so the sound energy is dissipating through mist or through saline. So that sound travels faster, which gives 18 times more the energy displacement onto those cells. So we're able to really excite those cells a lot more with the ultrasound had we not used any MIST therapy. Next one. Okay, so I mentioned earlier that that cellular response, really drives what's happening next. The cells get stimulated, then it creates ATP production, which you may have remembered from biology. It's really sort of the engine where things are moving, the mitochondria and the cells and the sugar production and so forth. That activation of the cell, that excitation enhances the metabolism, and then the magical things happen. Growth factors are released. What growth factors? There's many of them. To get technical, you may have heard of some of them. Insulin-like growth factor, vasoactive endothelial growth factor, platelet-derived growth factors. All these things are sort of the precursor to getting new skin and new healthy cells. We usually see the end product when a wound heals, but a lot of things are happening below the surface that the human body's taking care of. What we're doing here is really enhancing that, accelerating that healing process. And in that process, we're getting new blood vessel growth, which is called angiogenesis. And with the angiogenesis, we're getting better perfusion, right? So more blood flow means more nutrients, more oxygen, more growth factors, laying down of our platelets, laying down of fibrinogen, laying down of fibroblasts and the new skin cells. Eventually, we get collagen remodeling. As you know, the type 1 collagen is a big part of wound healing. And so as you get the growth factors, we get the laying of new skin once the collagen is deposed in there, and creates that scaffold that we all like to look at under a microscope. Once you get the collagen, the skin is healed, and then strong tissue repair occurs within a few weeks to months after the wound is healed, which is really without our intervention, but that's really sort of the precursor and the setup for the wound to really heal, but not just heal, but stay healed. Next slide, please, Billy. Okay, so that's pretty interesting, right? Okay, kind of told a lot of bit about the physical science, about what's happening here, and it sounds pretty neat theoretically. But we're not talking theory here. We're actually treating patients who want to see, does it really make a difference, and where does it make a difference? And the process to getting healed, we got to do other things before we actually go to closure. So if there's a lot of bioburden, dead tissue, bacteria, certainly the wound is not going to heal in a hostile environment. What UltraMIST does is reduces the bacterial colony count. This was a study done many years ago on pressure ulcers, and if any of you have seen or work with pressure ulcers, especially if they're in the buttock area or in the sacral area, they can be contaminated, dirty, moist. It's really where bacteria loves to float and live. So in this case, we see a study using UltraMIST. There's a small sample, just 11 patients using UltraMIST, 6 treatments, 3 times a week for approximately 2 weeks. So a very short duration, almost the duration as you probably give someone the antibiotics for 7 to 10 days orally. But as you know, all antibiotics are treating the body systemically, not locally. So in this case, you're using local treatment, ultrasound energy, and that really reduces the bacterial colony counts within 2 weeks, 93 to 100%, depending on the pathogen. In this case, the 3 pathogens, Staph aureus, which many of you probably see many of your wounds. We go to the end where E. coli is common, as you know, if this is the gluteal region, and then in not so common bacteria, Acinetobacter. The point that they take away from this slide is really the bacteria can be addressed, and colonization can be addressed with UltraMIST by reducing that inflammation, reducing the bacteria, and therefore going on to the next phase of healing. If many of you recall, the phase of wound healing are the first, the wounds bleed, right? If you get a cut, it bleeds, it coagulates, it clots. The next phase is inflammation, and that's where things go wrong. In the inflammatory process, the body's setting up stage to get the macrophages to clean up the wound and get the fibroblasts to clean the wound. But in that phase, in that second phase of healing, if you have a lot of bacteria, the wound gets stalled in the inflammatory phase. Most wounds are actually stalled in that inflammatory phase. So we have to get beyond the inflammatory phase to get to the next phase, which is granulation. I'm going to talk about that. Next slide, please. And the granulation is really neoangiogenesis. And I'm sorry, this came one in between, but neoangiogenesis is where that we talked about earlier, where you get the new capillary blood vessel growth. So that neoangiogenesis, we're going to get healing, we're going to get epithelialization, we're going to get scar tissue formation. Okay, so we talked about some things that happens with infection reduction. What else can happen? We're going to reduce the volume, reduce the size of these wounds. Once we pass the inflammatory stage, we've passed the angiogenesis stage, we've got to get to closure. Well, how fast does that happen? Is there proof or data behind this? Absolutely. As I mentioned to you earlier, I've been using UltraMIST for over a decade. I've seen this happen, proof in the pudding, but there's data out there. Thousands of patients have undergone UltraMIST therapy over the decades. Several studies made analysis, looked at 55,000 patients in the top of this pyramid, where 3 studies actually looked at that volume of patients. Approximately 8 randomized controlled trials have been in the literature covering over 500 patients. looking at the healing and success rate, particularly on diabetic foot ulcers and venous ulcers. And there's numerous case studies, retrospective studies, observational studies, but the rules of eight apply here. What is the takeaway here is that there's a lot of data regarding patient and patient healing, especially in the diabetic and venous ulcers, which are the most common type of wounds. And the rule of eights are there's approximately 80% reduction in volume within 12 weeks, approximately 80% reduction in surface area within 7 weeks. There's nearly doubling the healing rate entirely within 12 weeks compared to standard of care. And there's a 79 or almost 80% reduction in pain. So the rules of eight are 80% reduction in volume, area, and pain. And why is that pain there? As I had mentioned earlier, if we're reducing the pathogens, the bacteria, which really, creates an inflammatory response, and you bring those, horrible tumor necrosis factors and interleukins in the wounds, getting very technical here, but those are the things that really bother the microbiologist and those that work with wound biology, because that really interrupts the healing cascade. But that inflammation causes that extra sensory effect that the patients are feeling with their wound. And I think, I can tell you that my experience is often the patients have been suffering from these wounds for months and months. But the first thing they're looking for is actually, can you just make me feel better? Right? Obviously, they all want to heal. But can you just make me feel better? Because usually they're coming in saying, hey, do you have something for pain? Or, they're often just uncomfortable. They've actually gotten used to bearing the pain because that's just their way of life. And so usually within 2 weeks, most of my patients are coming back saying, I feel better. Their pain scores are dropping from 10 to 6 or 8 to 4. And that's success. So often, as you know, if you work with wounds for a long time, you don't always see the healing immediately change within 1 or 2 weeks. But within 3 to 5 weeks, you certainly see a big difference. In these studies, we're comparing a 12-week comparison. But we do see the first thing is that pain reduction. That's very rewarding and exciting, because then you improve patient compliance. They see a difference in the impact that you've made. They feel good coming to you, and they'll come to you often, because we know compliance is a big part of healing. Next slide, please. Okay, so patient selection. This is great. This sounds really neat, wonderful. I'm telling you about all the great things. What kind of wounds can we use it on? Told you the data about venous and diabetic. I've given you the data on pressure ulcers and contaminated wounds. But beyond that, you can use it on surgical wounds. You can use it on patients with radiation, Mohs, nearly any wound from head to toe. I've used it on scalp wounds myself, on flap and surgical adhesive wounds. I think almost everything is fair game for improving wound bed preparation. And what that means is, we're all trying to get the wound better, preparing it so it can heal, removing all the obstacles, slough, dead tissue, infection, improving blood flow, right? We're trying to do all those things on a cellular level. And if we have a tool that can get us there faster, work adjunctively to what we're already doing. Adjunctively means, sharp debridement with or without, negative pressure therapy if you need it, biologics can substitute. So if you're working with hyperbarics on a clinic setting, almost anything you can overlap it with. In the mobile setting, if you're certainly using this, it's a wonderful opportunity, because you have less tools in the field versus the clinics where they have hyperbarics and they have a lot of staffing and they have other cool tools and gadgets. While we're in the mobile area, you can only bring so much with you, besides a scalpel and some dressings. In this case, you can actually bring a very advanced modality that hits one of the five forks of healing wounds. The five forks being a debridement, hyperbarics, which you may or may not have access to, negative pressure therapy, compression, any other interventions such as biopsies, in this case, UltraMIST therapy. So it's one of the five big ones that you can do that really make a difference in the wound. Next slide, please, Bailey. Okay, so indications, contraindications. You can, as I mentioned, you can use it on almost any wound. In fact, you can use it over tendons, bones, arteries, veins. You'll see some case examples at the end of this to show you, where I've had some success using it. The areas that we want to avoid using it are really over electrical implants and pacemakers. Not to say you can't use it on a patient that has a pacemaker, you just don't want to apply the ultrasound directly over that. The other areas are certainly wounds that may be suspicious for cancer, skin cancer, squamous cell, basal cell, melanoma. Those are areas you really want to avoid using. Certainly if a patient has systemic cancer, bladder cancer, prostate cancer, breast cancer, it is certainly fine to use on those patients because it's really the wound that you're treating, not their systemic issues. And then certainly over a pregnant uterus. Remember, this is a treatment modality, not a diagnostic modality. So we don't want to do anything that can affect mother or baby, and try to just be careful to avoid that area. You can certainly use it on once again, pregnant patients, but just not over their abdomen where you may have some interference with the baby. And you can see the photo on the right. I'm sorry, just back one, Billy, real quick. The photo on the right shows, if you haven't seen UltraMIST in action, really kind of the rolling cart that can be used if you're in an office setting. But the actual device is sitting on top. This is just for convenience if you're rolling it room to room. But the device is actually quite portable. That can be brought in a little backpack kind of system, a carrying case if you're out in the field, and it's very portable. And there are cases out there that, various cases out there in the field that can be used to make it more portable and more mobile. So just to give you an example, if you haven't seen the device before, sort of how it looks in a clinical setting. We're good to go next now. Thanks, Billy. Okay, so for those of you who are concerned about purchasing this and what it costs and what it reimburses, what it looks like. So it is reimbursable with Medicare Part B. So that means any outpatient clinical setting, mobile setting, long-term care where they roll over into Medicare B. The average reimbursement in the country is nearly $400. And how many times can you use on a patient? There is a cap, just like we do on some other treatment modalities like biologic skin products. Medicare allows you to use it up to 18 sessions, so 18 treatments. The average number of treatments, by the way, which we briefly alluded to in the previous slides, but I didn't spell it out, is about 2 to 3 times a week. So you want to see these patients optimally 2 to 3 times a week. Now, can you do one time a week or 4 or more per week? Sure. I think the main limitation is how often the patient can be seen. In some cases, they can only be seen once or twice. That's not optimal, but I would say something is better than nothing. But the best results to really mimic the studies you've seen above or below, before, is really 2 to 3 times a week. So you do these 18 sessions. That means you can complete them in about 6 to 9 weeks in terms of the treatment to really get to the end point of improved healing or wound bed preparation. In the process, you're obviously reducing risks because you're improving the healing outcomes, and therefore there's less risk of litigation, especially if you're doing wound management, let's say in a post-acute setting, in a skilled nursing setting, or in a long-term care setting where you're dealing with pressure ulcers, and often those are acquired, whether it's in the hospital or in the facility. And your job going in there is really or your clinician's job is really to go in there and heal the wound, then as quick as it's possible to improve patient satisfaction. And the intangible benefit is anytime you can heal something fast and have a better outcome, the patient's happier. Usually they're not upset to do something bad and harmful to the clinicians. So and overall, when you reduce the duration of treating the wound, you typically reduce the expense. And so if you do the math, if you do 10 sessions of this and an average of $400 a session, it's $4,000 to give you an example. And over the course of treatment, it could be even up to 18 treatments, so $6,000, give or take. It can give you an idea of the return on investment to use this device. And it just makes sense to use it clinically, obviously. Next slide, please. Okay, this is a little more dialed-in breakdown of those 5 areas I talked to you about, that's the hub and spoke of areas that you can do good wound care, that's advanced wound care, that is evidence-based wound care, it's reimbursable wound care. So as I mentioned, there's only 5 things that kind of hit all those things in current day and age. There's more coming, obviously, but today there's just 5 straightforward ones that are covered by Medicare. We all do visits with the patient, whether it's mobile or inpatient or outpatient, and that has its own reimbursement by E&M codes and office visit codes, which is usually the lowest denominator. Then your sharp debridement obviously is a reimbursable code. If you have an office setting or hospital setting, hyperbarics, as you know, it has its limitations in terms of cost, in terms of who can do it, where it can be done. You have skin products, which have a lot of restricted criteria, they're getting stricter as we go in 2026. Who can use it, when you can use it, how much you can use it. And by the way, these days, how much you have to document to use it, which, as you know, if you don't document well and you don't justify these procedures, you're going to get someone that audits your chart and is going to be unhappy with it. So in this case, UltraMIST has a very simple criteria. We'll talk about that. Well, actually, I'll just touch base on this now. It's a very simple criteria to use UltraMIST, which is a non-healing wound or a wound that's not accelerating in healing within a month or 30 days of standard wound care. You can apply UltraMIST to that patient, especially their Medicare. You can also use on day 0 of the encounter with this patient if the debridement is contraindicated. Let's say they have a bleeding disorder, they're on heavy anticoagulants, or they have intolerable pain to sharp debridement. That can be documented as well. So those are the simple criteria to document why you're using UltraMIST. And then typically within 6 sessions, you want to document the improvement response with UltraMIST. No insurance, Medicare specifically wants you to continue to 15 or 18 sessions, but there's no benefit. So certainly you want to document the inflection point in your charts of, hey, the patient's responding. You may see photographic evidence of improved granulation. You may have size reduction, volume and area, or pain. And if you document any or all the above by the 6th treatment, which is within 2 weeks typically, then you have justification to go all the way to the 18th treatment, excuse me. So this is a very powerful case to use it because the documentation is easy. The hurdles are much less than the other forms of interventions. The reimbursement's good, and the clinical response is amazing. Next slide, please, Bailey. Okay, who can do this? Almost anybody that's in your office in a clinical setting. Mainly the provider, NP, PA, MD, DO, it has to be the supervising entity. So they have to be present in the building or in the facility, or if you're in the field. There are exceptions. There are cases now where if you're in the field with a mid-level, and excuse me, not just a mid-level, but excuse me, an RN, an LPN, an MA or PT, and you have a communication visit with your licensed provider, the UltraMIST can be performed as well. So if you're in the remote setting and you can't have your doctor go out there or your NP or PA go out there, and an RN LPN is doing the UltraMIST, as long as there's a communication live while you're doing that treatment, and that's documented, this can be done as well. So understand that this is a non-invasive, non-contact treatment, and that's why it's relatively easy to perform by anyone that's trained to do it, and they do not have to be licensed to do it. It's no different than taking your blood pressure, for instance. In fact, I believe that's even more invasive because you're actually squeezing an arm, and you can certainly hurt somebody if you do it on a dialysis fistula, for instance. So in this case, the level of harm or the risk is extremely, extremely low. And for that reason, we can do it. And speaking of risk, I did forget to mention earlier that the other area you do not want to use it over is use ultrasound, UltraMIST over the orbit or the eye itself, directly on the eye. I use it for facial wounds, but not. You certainly want to make sure the device is not triggered over the eye. Next slide, please. Okay, a few case studies. We'll spend a few minutes going through some of the case studies I've had fortunate luck with, and then we'll open up the time for some Q&A here. So the patient I've been seeing for quite some time. I haven't been seeing them for 17 years, but they had 17 years history of a venous ulcer that would wax and wane, but never close up, and it would be approximately this size. So it came to me with this history. First thing I think of when I have a wound that long is, okay, I better not a malignancy in there or an atypical disease or infection. So I biopsied the wound, and it was negative for any of those concerns. This patient underwent vein ablations because of the venous ulcers. So that's a standard process, a standard operating procedure if you have recurrent venous ulcers or not healing ulcers. Seen by a vascular specialist that can do vein ablation is part of the algorithm of care. This patient failed skin grafts, had vein ablations, was intermittently using compression. I was fortunate that the patient was willing to try to see me. It was willing to see me, but also remain compliant, because you always wonder if this patient's ever compliant. But she did see me regularly. We tried alternating dressings out there without much clinical response, so I quickly initiated MIST therapy. You can see it's a 13x4 wound. If we go to the next slide, you can see when we initiated MIST therapy, the very quick clinical response we saw within a few months. And this patient had it for 17 years. So I typically treat my patients twice a week because that's how often they can come and see me. And we can see there's no other change in other modality besides topical dressings, where there's an alginate or hydrofera. And you can see it went on to granulation and epithelialization within 2 months and full closure within 3 months. She actually started feeling pain reduction within the first month, where she was extremely happy and saying, "Oh, I feel nothing now," and was just pleased to come in because she felt better. Next slide,
So,
please.
Dr. Did you do the 18 treatments then for this patient, and then the trajectory just continued and she closed at 3 months? Is that
Correct.
correct?
That's a good question. Thank you for saying that. So obviously 3 months is beyond the 18 sessions. So we use up to 18 sessions. There were gaps in where she'd miss a day or in a week, so she'd get 1 session. But we extended as far as we could to finish the 18 session, and then she switched over to topical dressings like we continued and stopped the MIST therapy.
Awesome. Thank you.
In fact, I believe in the 2 months time frame, if I recall now, she actually received about 13 or 14. And because she was not able to come in that often, we switched over to topical in this case. So because she had significant improvement in 2 months, you could see, boy, why'd you even do UltraMIST much after that? Because she really didn't need it. Yeah, but I wanted to show close. You can see some wounds now that didn't close all the way, but they got much better. So you'll see that next coming up. Great question. Thank you. All right, so this is another gentleman that saw me not too long ago. I just discharged him maybe a few months ago. He was a 61-year-old male that had a leg ulcer for over a year. He was seeing some other colleagues in the area, and they referred him to me. He was seen by dermatology as well as rheumatology, because they thought this person had some kind of vasculitis, an atypical wound. It wasn't traumatic. It wasn't venous. We did not know really why he had this. What we did know is when you debride the wound got worse. It's called the pathogy phenomenon, if you haven't heard of that before. When a wound gets worse by debridement, it's a pathogen. You typically see that in diseases like pyoderma gangrenosum. This patient did not have confirmed pyoderma, nor did it entirely behave like that, in the sense of the blue discoloration on the edges or biopsy showing anything related to that. But rheumatology did do some panels on him, as was concerned with elevated markers that were non-specific, that he may have some vasculitis, but they weren't still sure. I did a repeat biopsy and it didn't really give me anything definitive either. So sometimes, 10% of my patients, I tell them, you know what, I may not discover why you have this. I hope two things. One, I heal you and I hope you never get it again, because then I'm really stumped if you get it twice and we don't know what we're dealing with. But in this case, I did not know for sure his diagnosis, but he failed Santor, which was enzymatic debridement, had autolytic debridement with honey, had electrostatic products like Ergoplene AG, and nothing really made the difference. He constantly built up slough on the wound, and as I mentioned before, I couldn't do debridement on this patient. Next slide, please. So we initiated UltraMIST, and we see the difference in 2 weeks. One was, you can see the wound is beefy red. It's a little small on that slide. So the slough would build up recurrently, you tell me, no matter what product you use. And now we get a stability in the wound bed, which is it's granulating and staying granulating without building up slough between intervals of visits. And he was very compliant, came in, and he really had a tremendous response within 8 weeks. I can't remember the treatment count, but I believe it was 16, because he did come in twice a week. And we healed him pretty quickly. So still don't know why he has it. Thankfully, he hasn't returned back. He's seeing rheumatology to finish up his blood work. But he did resolve. And so this is a good example where, well, we may not always know why they have it, but it's a non-healing wound that's failed conservative wound care. Let's do UltraMIST. And by the way, these kind of patients don't qualify for hyperbarics, for instance. They don't meet criteria. Could I have used a skin product on this at week 2 or week 4? Probably. Back in the day, with Medicare, I used to be a VLU, DFU, and I wasn't able to confirm that, so I wasn't going to resort to a skin substitute. On top of that, he heals so quickly that there was no time to even use that weekly. So it's a good, relatively low-cost solution for the insurance to take care of this patient in a very quick time span. Next slide, please. Okay, this is a great case of a crush injury, workman's comp. I do deal with some of those as well, because they come to our trauma center, they get stabilized, they get some surgery. And then our great orthopedic surgeons say, you know what, why don't you go to the wound center and they'll take care of some of the wounds before we bridge you to another surgery. So this person got to a motor vehicle accident, was work-related, sustained compound fractures to the left leg. He underwent surgical treatment with fasciotomies, compartment syndrome. He had a split thickness skin graft on the medial part of his leg, so the inside. On this photo, that would be the left side of that wound. You'll see scarring on the inside of that leg, and that's where his skin graft was there. The top of the leg was not grafted, so that's the wound I had to treat or maintain and heal. He had a hard eschar there, as you can see, a really hard necrotic dead tissue, and really wasn't softening up to Silvadene, honey, and silver gel. He was able to tolerate debridement, so we did that as well. You see it on the photo, but we also initiated hyperbaric oxygen treatment because he did come to our wound center. He is a crush injury, so he qualified for that. He had some sensation loss in his leg, so he had some nerve damage as well. So it's quite a complex injury to the lower extremity. And he's young, so we want to give him all the fighting chance we can, because he had many years of a good, healthy, functional life ahead of him that we wanted to get him back on his feet again, and he wants to work. Next slide. So we did debride the leg. We got some dead tissue off. Hyperbarics ended at week 4. Then I initiated skin substitute. And you're like, well, why did you use a skin product? And this patient doesn't have venous ulcers. Well, he's workman's comp and he was granulating. And they wanted him, quickly. He was anxious about using this because he read about it. So we gave him an amniotic membrane application weekly for another 4 weeks. So between week 4, which is the middle photo, and week 8 on the right side, we can see a slight improvement in size and volume, but just not quick enough. We don't see a wow factor or a significant reduction in size and surface area. So I overlapped MIST therapy at that time, and we can go to the next slide, please. Stop the biologic skin substitutes at 12 weeks, continue MIST therapy at 16 weeks, and you can see the difference. In this case, I was fortunate enough to use MIST well over 30 sessions because workman's comp and the case manager was willing to continue this. So between the 12 weeks and 16 weeks, we bridged with MIST therapy. We overlapped MIST therapy with the skin sub as well. And at the 16-week mark, you say, well, that's great. How come we don't see a photo of him healed? Because orthopedic surgery wanted to take him back for additional surgery and remove some hardware, and they didn't want to do that when he had a big wound. So he went to see his orthopedic surgeon at the 17 or 18-week mark. He supposedly healed back then. Surgeon took him to surgery, and he never came back to my clinic. So he called me on the phone and said, hey, wound's actually healed. Sorry I didn't come back, doc. I'm doing great. I'm like, okay, thanks for letting me know, but you messed up my slide deck because I can't show a cool wound.
So I can
It
take a
doesn't matter.
picture.
Right? I take a picture, and for me, and I could have done that actually. You're right. We do that sometimes, but for me, I wasn't even thinking about a case study. Right? We treat these patients all the time. He's just another patient. So when I work with Sanuwave and they say, hey, you got some cases, I'll pull a case like this up, not thinking, oh boy, someday I'm going to want to present this, because I've been doing it so long. I take it for granted that this is sort of an everyday event. We see so many patients get better with this. That back in the day, I have slides maybe 15 years ago I could show about, but they look dated, and where I used to take photos of these things and say, oh wow, look at this, it's doing great. So we take it for granted how good of a job UltraMIST can do. Next slide, please. Okay, so some key takeaways. We're done ahead of schedule, so we have time for Q&A here. But to recap here, I mentioned that UltraMIST works in 3 fashions. It reduces infection and therefore reduces inflammation. It creates new blood vessel growth, which feeds the wound with blood supply and gets all that growth factors in. Helps heal the wound fast because of those 3 things. It can be used on most wound types. We talked about it before: surgical, diabetic, venous, radiation wounds, pressure ulcers, you name it. Head to toe, no eyeballs, no pregnant uteruses, no hardware, no electronic hardware. 2 to 3 times a week, up to 18 sessions. And yes, you can overlap that with other modalities, just like we did with that crush injury case that we just showed. Next slide. Okay, good. I thought we were done. So went through it fairly quickly. I skipped on some slides. I have a longer deck that goes over a little more sound physiology and physics, but I didn't want to spend the bulk of our time in that. It was more to give you an idea of, hey, this is how it works. There's actually real science behind it. There's real data behind it. We can certainly share with you some of that literature if anyone needs that in the audience. But I'd like to open the time up for any Q&A.
Yeah, so there's a number of questions in the chat that I'll go ahead and share with you that came in during the presentation. One
Wonderful.
of them early on was, is it heated? I think they were talking about the actual mist going into the wound and whether that is warm or not.
No, it's at room temperature. So there's a bag of saline, normal saline, that's hooked onto the device, and that's just sitting at room temperature. It's not in a warmer or anything like that. So unless you're working in an outdoor cold environment, which hopefully you're in someone's home or you're in the clinic, it's going to be at room temperature.
Okay. There was another question that said, does it connect to an EMR or laptop?
Good question. No, it does not at this time. That's something that I believe the company is working on, but it does not directly work. And you do have to plug in the measurements on there, whether you have a photo system tool or you're using a measuring tape. You plug in the dimensions on this device, on the UltraMIST. Those dimensions will tell you the duration of how long you can treat it. So the digital interface, if you're looking for that, it's not at this point communicating with any of your EMRs. But what the digital interface does include is once you enter in the size of the wound, it'll tell you how long to treat the wound. And to give the audience an idea, about a 25 square centimeter wound will take 5 minutes to treat, and that will be programmed to the device. But no, at this point, it does not integrate with an EMR.
Okay. Another question on licensing requirements, which I think you did answer in that slide. So the different specialties that can do it. Another question was on insurances that pay for it. So if there's commercial or Advantage plan coverage.
Mhm. So University Medicare does cover in all the MACs throughout the 50 states and the territories. Medicare Advantage follows Medicare guidelines. The only difference is in Medicare, as you know, you're not submitting an authorization, although there are 5 states that you do now have Medicare with the new ruling. But Medicare Advantage just requires you to submit authorization, and they do have to follow Medicare guidelines. So you should get approved if you hit any problems there. I know Sandy Wave has a resource hotline with their billing and reimbursement to make sure that does not happen. They take care of the fight. In terms of commercial, it depends on the region, state you're in. I do work in Arizona as well as a little bit in Texas, and we know, for instance, Humana is pretty straightforward, and they do cover it. All the other insurances, your Aetnas and your Blues, it's case to case. You have to submit the justification for it, but it's not universal in their policy. United, we're finding that they're following more and more Medicare policy because they follow their LCDs in many states, but it's not universal that they're covering it. So as a blanket statement, I tell all my clinicians and colleagues, expect to request authorization commercial, and it's not universal they're going to cover it. Medicare it is, and Medicare Advantage with prior auth, which they follow guidelines.
Awesome. There was a question on whether or not this information will be distributed following the webinar. Yes, this is recorded and we will upload it to YouTube so you guys can find it later after the fact. Are there EOBs if doctors ask from those payers? Maybe that's a question for the team at SonuWave.
Yeah, they do have that. Our CS team has that, and I've seen it myself. I just don't have the distribution list, but we can provide that, or they can provide that.
Okay, I will work on getting that for you guys.
Absolutely.
Tara asks, does it debride the wound?
Yes, it does. And I don't stress the debridement part because don't equate that to a scalpel or some of the enzymatics out there that's all they do. This does have debridement properties. So if you use it on an eschar that's lifting off or some slough, it's going to loosen it because of that sound energy and because of the inflammatory cascade. It's going to, the reduction in inflammation actually reduces the slough buildup as well. But you're not going to get the same results as sharp debridement.
Okay. Another question is, we can only see this patient once per week. So how would this work if they need 2 to 3 treatments per week?
So we recommend 2 to 3 treatments per week to get the outcomes of the wonderful photos you saw, because that's where all the data is and that's where we see great results. So if you cannot see them 2 to 3 times a week and it's impossible to do that, then you're limited to 1 time a week and there's nothing else we can do about it. The main thing is Medicare allows 18 sessions and they want to see improvement at 6 sessions. And if you do 2 or 3 times a week, typically the sessions are done between 6 and 8 weeks. So typically a lot of the MACs are saying you cannot use UltraMIST beyond 6 weeks, not because you can't use it, but because you should have finished 18 sessions by then. You haven't. So the main thing is you may cap off the number of weeks you can possibly treat the patient, even though you haven't exceeded the 18 sessions. So yeah, use it as best as you can. You may not get a complete clinical response. I hate for you to come back saying, Dr. Shah, you told me it's going to get better and it didn't. And use it once a week. And I'm like, oh, that's probably why. And look, like anything else, there's nothing perfect. This doesn't solve every problem and every wound, but it's a great adjunct. But we'd say try to use it. Something's better than nothing, but you may not get the full clinical response once a week. But you can certainly do that.
Okay. Another question is the NP reimbursement less than an MD if in a mobile setting?
Yeah, it should be 15% less, like any other procedure.
Okay. Another question, does SonuWave offer appeal support?
So they do have a billing specialist out there that can help assist in writing a template or a draft letter. I cannot quote for them that they'll physically fight the fight with you, peer to peer. But I do know that they help with templates and guidelines to help anybody in the field go ahead and put in that submission for an appeal. So I do know that they've done that, but I'm not sure they'll physically be able to get on that phone call with the insurance. Sometimes I've done that, where I'm seeing a patient, I'm calling the medical director from Blue Cross saying, hey, you got to do this. It's not getting better. My options have exhausted, or patient's hurting. What would you do if this was your mom, kind of thing, So, but there are standard documentation we provide to show why, the insurance should cover it.
Awesome. Okay, what are some tricks to help usage flow more easily and quickly?
So I assume that's an operations question, like how do I fit this in my practice and make it flow? I think I want to ask a question back. I don't know if you get that. It depends, right? So if it's in a clinic, it's a little different than in a mobile setting. So I'll start with the clinic first, and then I'll go to a mobile setting. So if you're in a clinic, it's pretty straightforward in an office setting because um, if you're 4 or 5 exam rooms, the clinician's seeing the patient, they do their thing, provide advice and guidance, a plan of care, they leave and go to see another patient. Once they've left that room, the nurse, LPN, MA can all go in that room while they're talking to the patient, getting them ready to leave. They can do UltraMIST, do the education while they're UltraMISTing them, and then dress the wound and go. So that's the flow. And like I said, probably adds 5 to 7 minutes of their time. Sometimes it doesn't because you're overlapping the communication because you're always talking to the patient before they go and dressing the wound. So you can often overlap and save the time there. In the mobile setting, you basically have to factor that time in. The larger the wound, the more time you need because the device is programmed based on size of the wound. So 5 to 7 minutes for a 25 square centimeter wound, and then it goes onwards from there. So could you add 10 or 15 minutes to your visit time because you have a massive leg wound? Sure, but hopefully it gets better quicker and it gets smaller, so you're spending less time in the future, and you do not get reimbursed by surface area. So that's a question coming up. Even though this treatment duration is by size, the treatment reimbursement is not by size. So whether you have 5 square centimeters and you take 2 minutes to treat it, or you take 20 minutes to treat it, the reimbursement is the same.
Awesome. They asked, can you go through charting requirements for documentation?
Yeah, I'll allude to that before I kind of touch base on that, but let's start with the easy one. 30 days of documentation of not responding to standard wound care. Patient comes in, you may or may not have done debridement, you've done offloading, optimized sugars, put on good dressings, and the wound has not a good slope. And then if you could see, I don't know if everybody can see my screen, but I'm drawing a line like this. A slope means it's dropping in size. It's when it's flatlining and not dropping or dropping very slowly. Typical wounds have to heal about 5% per week to 10% per week. Should be about half the size in a month to 6 weeks. If your wound is not healing that rate, you can document wound not healing appropriately or wound not responding at 30 days, and then you initiate UltraMIST therapy. And then at the 6th treatment, you document what the response is to continue the wound treatment. Wound size is smaller, less slough, more granulation, any of those words that would be in your typical note, you would write again saying why, like anything else, why would you continue a dressing or why would you continue an ointment? You probably want to document patient is responding to that ointment or to that dressing. It'd be no different than saying that. Now, that's the easy part. The other way to do this, it's easy, but you just have to document that day 0, is you want to start this the first day you see the patient because they're coming in. One, they may have had wound care before you saw them, and you can say 30 days of wound care and what that was from their history. Or two, they have not, they cannot be debrided. They cannot have other interventions in the next 30 days because they're on anticoagulants, cannot take them off because of the bleeding risk. Maybe it's near the part of the body that's a high risk of injury. You're right by a tendon, you're right by a blood vessel where you can't really be very aggressive with it. You can't even put negative pressure therapy in that area, maybe because it's high risk. And or they have significant pain that's intolerable to physical interventions. Because remember, this is non-contact. So any other device that says they work with ultrasound, they're typically a contact ultrasound debriding tool only, not a energy modality to stimulate healing, non-contact, and reduce pain. So I do also want to say that ahead of time that this is, there's no other device like it. There's 20 kinds of scalpels, there's 100 kinds of ointments, there's various sizes and shapes of hyperbaric chambers, but there's only one device in the market that can actually do this, what it does scientifically without touching the patient.
Awesome. Thank you. So
Yeah,
there's
sure.
another on billing requirements and whether they're subject to consolidated billing if delivered at a facility by a mobile wound care provider.
So I was just having a discussion with our reimbursement person. We had a big win this week, and we're going to kind of have a formal printout on how that looks. And I'm going to apologize before I say this because I'm not a billing reimbursement specialist, but we just got off this phone call. We just got it unbundled for long-term care. So if a patient's residing in a facility and they transition to long-term care, they roll over into Part B in that long-term care. Before it was coupled and bundled, and you still would have an issue. As of this Monday, we actually have a link and a proof on the Medicare website, CMS, that it's uncoupled. That is fresh off the press. I do not want to kind of mislabel it if I kind of didn't say it right or give the site of service right, POS 3132, because I'm not the billing expert, but literally we're excited because that just changed this week. But I would like our billing team to send that out to make sure that, it's clear in black and white, so you're not getting the wrong kinds of codes in for that. But I want you to be excited, but just cautiously wait for that sort of information to roll out. And I believe David Goko, who you've been in contact with, he was on the call with me earlier today, so he should be able to get that information to you probably by next week.
Perfect. I will
Yeah.
work on getting that from him, and then we will add that to the link where we've got this posted on YouTube so that you guys can
Mhm.
download the resources that we're talking about here as well.
Mhm.
Okay, a couple more questions. There's quite a few coming in, which is a good problem to have.
Okay. Yeah.
Does the system require regular updates?
The system as in the UltraMIST?
Yeah, the gen-
Software updates like an iPhone? No.
that's what I
So
was.
it's barely changed in form and factor. 15 years I've used it. It works as is, so it's good. The updates may be a new generation version that we're kind of maybe talking about, but um, if you get the unit today as is, which is the same unit I had for 5 years, it's not going to have a software update coming in and stalling things, or you missed out, like you bought a Tesla today and tomorrow Elon announces a new Tesla. You're not gonna have that situation.
Perfect. Okay.
Yeah,
Another question, can it be used with SoftWave or is it one or the other?
one or the other. Yeah,
Okay.
because I want to make sure, because software, I believe it's using the same CPT code. If it is, then you don't want to overlap the CPT codes.
Mhm.
Once again,
Okay.
not a billing expert. I don't use SoftWave, but I do know you can't overlap the two.
Sounds good.
Yeah.
Okay, there's a question. Can the UltraMIST be rented? So we do have financing and leasing options available for you guys. Reach out to myself or someone from our team and we can talk about what that looks like for a rental option.
Thank you for answering that for me.
Yep. And then if the wound heals with UltraMIST, then reopens, does the patient get another 18 treatments?
So, like, if it opens up the week after, probably not. You can create a new incident if, because it happens. For instance, we have venous ulcers that recurrently reopen months later because they got sloppy by it or they hit it again. You have to create a new incident. Um, Typically, I've seen in the past, that you want to do it after years expired. There's some max that may give a trouble if it's the same wound in the same location, and you're doing it again within the same year.
Mhm.
That's sometimes where things get a little, unknown. So I hate to say for sure, but definitely for years past, this shouldn't be a problem. But if you're having it back to back, you probably want to wonder, well, why are they opening up again? It's something in their what we call activities of daily living or something underlying in their physiology. It's not the device that wasn't good enough to help them, stay healed. So
Okay.
in general, I'd say probably not in the first year.
Mhm. Makes sense. Someone asked, do you know the weight of the machine? How heavy is it?
Oh God, I should know that, shouldn't I? Don't quote me because I don't lift it myself. My staff rolls it around. And David can tell, but I'm guessing if I had to guess, it's under 10 to 12 pounds. I
Yeah, I
have
was
to
going to
guess.
say it's, about that big, I would say,
Yeah.
right? You
Yeah.
can carry
It's
better if you've got a rolling
okay.
cart.
We've had, and look, I'm tall, so I'm 6'4", but I've had my short 4'5" French nurse that has a body weight of 80 pounds, move it around, lift it and move it. So I know if she can do it, you know, most people can do it. And we have a lot of people in the field, thousands of practitioners in the field are going using mobile. Mobile is the quickest growing space that people are taking advantage of this device. And no one's called back saying, boy, it's too heavy. It's more about, oh, can we use a different brand of box? Or can we use a backpack? What can we use? There's different ways you can pack it up and bring it into facility. We have those options, but it shouldn't be a problem. Yeah.
Okay. All right. Another one is how easy/difficult is it for providers to purchase the attachments and replacements? I can answer this one as well. So in our Venture One View portal, you guys can purchase them. They come by the case in a case of 12. And then you can also run insurance verification requests in our system as well. So it's a very easy way to order. All right. How do you dress the wound after the treatment?
At your choice, whatever dressing, whatever flavor it is of the day that you're choosing to do is fine. You can continue the dressings you've been doing before using UltraMIST. Whatever dressing you think will help that wound bed. There's no restriction.
Awesome. All right. When can it be used in the acute phase? Patient on anticoagulation meds or any other instances?
Maybe you got that question 15 minutes ago because it's exactly what we answered,
So,
which is
but,
if they're on anticoagulant therapy, if they're contraindicated to debridement because of pain, bleeding risks, you can start using it. Just document that. You may know that, but whoever's reading your chart may not know that, even though there's Xarelto on their med list. Just to have that documented in that plan of care, why UltraMIST was initiated day 0. And to your point, you just go for it.
okay. I think we may have answered this one as well in a way, but I'll re-ask it just to make sure. Does a non-healing wound need vascular studies before starting UltraMIST?
It depends. So if you have a lower extremity wound, we always say, the foot or the lower leg, I always say no flow, get a flow. So if your clinical exam says they got good flow, and they got good dysospedes and good cap refill, and they're not a smoker and they're have a low risk factor, you don't need a vascular workup. They're probably not healing for some other reason. Maybe it's infected. Maybe they're not wearing compression. Maybe it's, they're around animals because I have patients, if you have 3 or more animals, you see animal hair in there, they're probably getting contaminated. So it depends. If you suspect blood flow issues, cap refill, they have a vascular risk, they're a heart patient or stroke patient, that means they're probably a peripheral vascular patient. You should get arterial studies because you don't want to do this therapy and then get nowhere with 18 sessions and then think, oh, this doesn't work. It's
Mm,
because you got to deal with the macro flow. So there's plumbing, right? There's large plumbing and small plumbing. There's large arteries and small arteries, and there's arterioles and capillaries. You got to first fix the big blood flow areas, which is usually where the vascular folks come in. The microvascular, which is a small capillaries feeding the wound bed, that's where they can't go in and put a stent in or a balloon in. That's where we got to work with the wound, and that's where UltraMIST can open up and dilate those blood vessels. But they're not going to do that. UltraMIST is not going to work unless the major blood flow is open. So yes, get the vascular folks to open up those arteries, those big arteries, if that's an issue in the lower extremity. Now, if you have a chest wound, an abdominal wound, a pressure ulcer, no need for a vascular surgeon. Head wound, you don't need. So unless there's reason for claudication, circulatory compromise, risk for peripheral vascular disease, then you should get the vascular. Otherwise, you don't.
okay. Next question is, how does the water cycle and dispose?
So it's just saline. It's the bag's thrown out, the tubing is thrown out, and the mist is going onto the wound, the saline. So it's a Gillette cartridge. You throw out the applicator, which is the 12 applicators you mentioned. You throw out the applicator, carry the saline, the tubing, and start over again in the next room. And you do a clean wipe or sterile wipe with the machine.
Okay. The next question is, can you exceed the 18 treatments and exceed 6 weeks if you are seeing continuous progression?
Yes. So let's say you have a large wound, 30 by 30. It's probably not going to heal within 6 weeks, right? So big a wound. But that 30 by 30 may be a 15 by 15 by then. So you've improved, you documented. You're going to have to document due to surface area and size of wound, patients clinically responding need beyond 18 sessions, and you create a new window of another 18 sessions basically and do it again. If you get audited, which you may, because I'll be there, because the computer algorithms just see 18 sessions. That's
Mhm.
when you have to put the documentation in and appeal and say, this is why, and then it's fine. So don't be shocked if the algorithm says, oh, well, you went beyond the number of 18. But there's nothing wrong with doing it. It's clinically appropriate. It's ethical. And there's a reason why. And the reason is you have such a big wound. That's what's
Mhm.
responding. Yeah. It's typically where we see it exceed the sessions because of size.
Yep. Okay. Can we bill for the UltraMIST and other procedures such as a sharp debridement in the same visit and get reimbursed for all?
Um, the dual modifier 59 for dual procedures, typically going to get paid 50% of the less expensive procedure. In some cases, they don't like you bundling it up for a double procedure same day, you may not. So there are cases where I've seen people not get paid on both, but in general, what I've seen when I've done it is you get 50% on that. So we try to stage and do it in a separate day. What we also find is that there's a time to do sharp and there's a time to do mist, and I usually don't need to do both the same day. So I'll do the sharp debridement today, make sure the wound bed's prepped, and there's no longer sharp debridement done. We find that usually after 2 or 3, 4 weeks of sharp debridement, the need to do it drops significantly, and then I transition to UltraMIST, so I don't do both at the same time. Or if I'm fortunate to see in my clinic, because I know most of your questions are coming from mobile, but if I see in my clinic, I'll debride them day 1, and then day 3 and 5, they'll come in for a nurse visit and they'll do the UltraMIST, for instance. So it won't be the same day. But in the mobile setting, I recommend you do one or the other if you can. Otherwise, you're going to get half the amount.
Okay. Perfect. There's another question. Can you provide a picture of the unit with the stand on the website? I'm guessing that's something you guys have and I can get from David to share as well.
Yeah, I hope it's on the website. If it's not, I have to double check. I'd be so maybe oh, it's probably not on the stand, but it is
Mm,
as a single unit. Certainly you can share that slide deck so they can see the photo of the stand in there. I think it's in the middle of the deck.
Okay,
But
perfect.
feel free to throw that to David. He can then forward it to our web and IT folks and see if we can put it somewhere there. It's a good point.
Sounds good. All right, the next one is this product in with the Veterans FCC contract? I think
I
it
don't
may
know
be,
for sure.
okay.
Yeah, don't quote me on that. I'm not sure. So I hate to give the wrong answer. We can find out, or
Oh,
we can ask David as well. We have
all
some
right.
VA contracts, but I can't quote exactly where.
Sounds good. We are about at time. I do see a couple questions about cost and more information. I just put my email in the chat and we will send a follow-up with a link as well that you can click for more information. So I can give you pricing and those specifics there. And then we will also upload this deck along with the YouTube link. Once that is live, you'll be able to see it with the recording.
Thank you,
So
Bailey. Appreciate it.
yeah, I
Really a lot of
appreciate
help.
you.
It's
It was a
fun.
great
Yep.
call.